Welcome to the DocTalks Podcast, a conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. I'm your host, Ian Gillespie, and I'm here to ask the questions and find the answers you need to know. We want to help our listeners know how to prevent and detect illness and how to navigate our healthcare system. Be sure to subscribe to the DocTalks Podcast to stay up to date on new episodes, and follow us on Twitter at St. Joseph's London, or visit sjhc.london.on.ca/podcast. Hello, I'm Ian Gillespie. Welcome to the DocTalks Podcast, brought to you by St. Joseph's Healthcare London. It's a well-known fact that humans can't survive without food. So what happens when the food you eat can sicken or even kill you? I'm talking, of course, about food allergy. And here with me today to help guide us through this topic is Dr. Samira Jeimy. And Dr. Jeimy is an allergist with the Allergy and Immunology program at St. Joseph's Healthcare London. She's also assistant professor and the program director for clinical immunology and allergy at Western University. Dr. Jeimy, thanks for joining us and welcome.
Thank you for having me.
So the stat I have in front of me is that more than 2.6 million Canadians, including nearly 500,000 children, are living with food allergies. My math calculates that it's about 6.5–7% of people. So a lot of us are familiar with allergies, but perhaps not the details behind them. Let's just start with the basics. What causes a food allergy?
What causes a food allergy? So in terms of the basic definition of what an allergy is, it's an inappropriate response to something that your immune system should not wake up and respond to. So in the environment, we shouldn't really be reacting to things like tree pollens or cat dander, but our immune system decides that these are not great for us. So the immune system reacts. As a result of the reaction, our nose runs, our nose gets congested, our eyes itch and water. So with foods, it's a similar phenomenon where the immune system unfortunately mounts an inappropriate response to something that it shouldn't. And how that comes about, that's sort of a matter of debate. There's a lot of hypotheses. The most sort of well-established hypothesis, I should say, is called the dual allergen hypothesis, where if your immune system sees food particles through skin that's broken down. So for example, I'll use babies with eczema, for example. Their skin is a little bit broken down, the skin is inflamed. If the immune system sees food particles through the broken down skin, it mounts a defense response to those food particles, as opposed to if it sees the food particles via the gut, which actually is a way to establish tolerance to the food. So if you have heard about how we have changed our paradigm of allergen introduction to babies, we now aggressively introduce foods early. That's the reason why, because we want their gut to see the food before their skin does. So that's one hypothesis. Another very well-established one is the hygiene hypothesis, which many are familiar with, which is that, in sort of industrialized nations in particular, we're not exposed to normal everyday microbes as much as we should be. So our immune systems sort of then skew towards responses to things that are innocent in our environment because it just hasn't had a chance to develop in the way that it should. Clear as mud?
No, I didn't realize that the skin had that much to do with it.
The skin the skin is very important. There's trillions of organisms living on your skin, and it's actually fascinating how those organisms in the skin and in the gut really, really shape our immune system.
So we also know that I guess there are certain foods that are more prone to cause allergic reactions in people than others. And I've got a list here. I'll just run through them. You can shellfish, eggs, fish, milk, mustard, peanuts, sesame seeds, I guess, soy, tree nuts, and wheat and triticale. Triticale. Does that make sense? Those are some of the 90%, it says, of allergic reactions are linked to one of those foods. Are there some others that we need to mention, or?
So in my head, I sort of go in order of prevalence. So, okay. I would go peanut, milk, tree nuts, sesame, soy, shellfish, fish, and then there's a new one. Mustard is sort of more recently added, and wheat is another one that used to be uncommon, but increasingly common. And then there's actually a lot of ethnic differences. So interestingly, native-born Israelis, for example, do not have any peanut allergy, but Jewish populations in North American continents actually have high rates of peanut allergy. And the same goes for South Asian. There's no such thing as a wheat allergy in India, but there are lots of Indian patients with wheat allergy. And then the same goes for shellfish and Southeast Asia. So it's actually quite fascinating.
Sorry, you're saying that Indians in their native country don't suffer from wheat allergies, but
yeah. So I mean people who are sort of have been living for generations in North America. They seem to have a different profile of the immune system. And, they seem to be almost more prone to developing allergies that are very, very rare in their ancestral sort of homelands.
So is this indicating that then environmental factors are playing a huge part in allergy?
Exactly. So what is it about our diet? What is it about our environmental exposures? Are we exposed to more pollution, for example? Are we eating more processed foods that's making the gut bacteria unhappy and sort of leading up to developing these allergies? And just by virtue of eating certain foods more commonly, you might identify a specific allergy in a specific ethnic population too. Like I'll give you that, but it's actually a very interesting phenomenon that we see all the time in different ethnic populations.
Wow. And I don't know if you would have the answer to this. Are allergies, food allergies, becoming more prevalent? Are we seeing more and more people allergic to certain food?
It is an increasing phenomenon. And one interesting thing is that adult onset food allergies are becoming more common. Classically, we're taught that food allergies come about in childhood, right?
Right.
Rarely did you ever diagnose an adult with food allergy. Not so much anymore. In fact, adult onset shellfish allergies are fairly common. And we can sort of get into why we think that's the case.
Okay. I'll bite. Yeah, why is that?
So a lot of people have allergies to an environmental allergen called dust mites, right? So dust mites are microscopic. They, get their water through the skin. So they like to live in our mattresses, our pillows, wherever, they have access to water, wherever it's dark and sort of humid. They have this protein. The protein is called tropomycin. That same protein is actually also in shellfish, so especially the crustacean variety of shellfish. So we think that, in adults, this environmental allergy to dust mite evolves into a food allergy to crustacean shellfish because it's the same protein that you are reacting to. And people are often surprised by it because, they've been eating shellfish their entire life, no problem.
Right.
All of a sudden, they'll have anaphylaxis to shellfish.
Wow. And of course, anaphylaxis, which is the most serious, is that right? That's the most serious reaction that you can have?
Not necessarily. These are all very serious, but anaphylaxis tends to be high profile.
And again, I've got a list here of symptoms of anaphylaxis: skin hives, swelling to the face, lips, tongue, itching, warmth, redness, respiratory problems, stomach problems, cardiovascular problems. There's actually a huge list of symptoms here.
Anaphylaxis can be tricky to diagnose because there are things that can mimic it, and also it can start out subtle. So, if you do have a diagnosis of food allergy, it's really important to empower yourself with the knowledge of what anaphylaxis is. There's 3 different definitions. So one definition is that that you've had exposure to your allergen and you have a drop in your blood pressure. So basically the blood pressure drop can manifest as feeling dizzy or actually passing out. That counts as anaphylaxis. So you don't necessarily have to have any skin or breathing problems. Another definition is you're exposed to your allergen and any 2 body parts are affected. So it can be skin and gut. So you can have, hives and diarrhea, hives and vomiting. You could have, a sensation of dizziness and breathing symptoms. So, any 2 body systems are affected. Plus, that you've been exposed to your allergen. And then the third one is probably the one that has the most awareness, is that you have skin plus. So you have hives plus any of breathing problems, cardiovascular problems that can manifest in dizziness or passing out, gastrointestinal problems, etc. So a lot of different definitions, so great to be aware of it and great to give that adrenaline fast if you know that you're having anaphylaxis. There's other kinds of adverse reactions. So anaphylaxis is one of the immune system reactions that we commonly hear about to food. There's all kinds of other reactions to food. One is called eosinophilic esophagitis, where you have infiltration of allergy cells in your gut and your esophagus, so that the inflammation actually causes scarring and causes episodes of reflux and choking. So that's called eosinophilic esophagitis. There's also food protein induced enterocolitis, which is F-pies, not a grape pie. So F-pies is you eat the food and then 1 to 2 hours later you'll have vomiting to the point that you might need emergency department visit for IV fluids. That happens too. So these are all different sorts of immune reactions to foods that are increasingly recognized.
I mean, a lot of people might be sensitive to a certain food. They say a certain food makes me feel unwell and so forth. But is there a difference between a food sensitivity and a food allergy?
Absolutely. So food allergies tend not to be subtle. You eat the food, within seconds to minutes, you have a reaction, and that reaction is, again, not subtle. You break out into hives, you get swelling, you get breathing problems. Food allergies, tend to be one of many different adverse reactions to food. So absolutely, there's a possibility that you eat a food. For example, I'll take gluten as an example. It's a very common one. If some people eat gluten-containing products, they don't feel well. They feel kind of sluggish. They can get nausea. They can get vomiting. They can get diarrhea. That is not an allergy. So allergies are immediate, and they tend to follow those definitions of anaphylaxis that we've previously talked about. Sensitivities or intolerances can be quality of life limiting, but typically not life-threatening. Over time, these intolerances can get worse. As we age or as our gut flora undergoes changes, they can get worse. But very sort of different things. And oftentimes, patients will come in with an intolerance, and we'll sort of have a discussion that, if I do a skin test, if I do a blood test, it's likely not going to be positive because my test picks up the anaphylactic type allergies. Those food intolerance reactions require more work in diagnosing. So what they entail typically is complete avoidance of the food for at least 4 to 6 weeks, and then challenging yourself with the food back in your life and seeing whether the reaction is provoked again.
Right. So, Dr. Jeimy, someone suffering a food insensitivity or intolerance, they go somewhere else? So they're treated in a different department than someone with a veritable food allergy?
So yeah, that's right. So from the allergy side, we can sometimes ease a patient's mind and do the skin testing and sort of talk to them about the fact that this is not a life-threatening reaction. And then we will often suggest to have additional workup. For example, gluten sensitivity should be worked up, and celiac disease should be ruled out because celiac disease can have long-term consequences down the line. If a patient has multiple food sensitivities, you have to think, is there something going on with their gut? And that's when we send patients to a gastroenterologist to rule out a gastrointestinal disorder.
Of course. And so if someone suspects that they're experiencing these symptoms, how is it diagnosed by a physician?
That's a great question. I think there's this sort of impression out there that, you come to the allergy clinic and you get poked by a lot of different things. And, that's part of the picture. So food allergy diagnosis requires, I would say, 3 or 4 steps. The first and most important step is your history. So anaphylactic allergies are an immediate phenomenon. So you're exposed, and then, 5 minutes to 30 minutes later, you have the symptoms. So that's a key clinical history characteristic of, an anaphylactic type reaction to a food. If you have a food and then 48 hours later you have a symptom, that's not really likely to be anaphylactic. So the clinical history is super important. Based on the clinical history, we then sort of direct our investigation. So this can include skin testing, whether with prepared extracts or fresh foods. Sometimes we add blood tests, and we now have pretty sophisticated blood tests that actually break down foods by specific components. So, we can actually test the specific component of peanut, for example, that makes you more prone, that puts you at higher risk of maybe having anaphylaxis. So skin test, maybe blood test, and then the final step is called an oral challenge. And an oral challenge entails feeding a patient the food that is their suspected allergen and incrementally increasing doses up to about a serving size of the food. And this is usually done in a monitored setting where if there's anaphylaxis, then we can manage. So those are the sort of different steps in diagnosis. If the history is quite clear cut and the skin test can also sometimes be very clear cut, then we don't go and do an oral challenge all the time because, we kind of know that there's almost 100% risk of anaphylaxis. But typically it's a 3-step process. And at each step, you determine what's this patient's risk of reacting again to this food if they eat it.
Wow. So that process, how long does that whole process take?
It can take time, and it's sort of dependent on what the patient's history is, right? So if somebody has never eaten a food before, we tend to have a low suspicion that the patient is going to have a reaction. Their immune system just maybe hasn't seen the food before, and that's true of babies. So babies, when they first get introduced to a food, even if they have a reaction to the food, it tends to be mild and sort of restricted to the skin. Their immune systems are just not mature. Their immune systems have not had adequate exposure to a food to build up, the immune system army response to the food. So we usually have more of an aggressive stance, I guess, on introducing a food to the baby's gut as fast as we can.
Right. So, and that I was going to go somewhere else, but I'll skip ahead quickly. That sort of leads into, I guess, one of the myths surrounding food allergies, that you should avoid certain foods for a baby, right? You hear parents say, "Oh, no, we don't want to give them peanuts or peanut butter to avoid this," but in fact, that's false, correct?
That's the opposite. So so there's been this huge paradigm shift that's happened in how we introduce allergens to babies. And previously, I would say 2016 and previous, the thought used to be that, we should avoid giving babies allergenic foods to reduce their risk of developing food allergies. But remember how I brought up the Israelis and peanut allergy? Somebody noticed that and did this ginormous study on babies who are actually at higher risk of allergies. So babies who have eczema, babies who have an allergy to another food, took those babies and actually divided them into 2 groups. One group got introduced to peanuts early, another group delayed, like we used to, prior to the study. So the study is called the LEAP trial, and it's this sort of practice-changing study where the kids who got introduced to peanut early actually had significantly less rates of peanut allergy, and that effect could be followed through in time longitudinally. So even when they were 5, 6, 7 years old, their risk of peanut allergy is still significantly lower. And that has been imitated with other foods, including eggs and milk. And now there's more studies kind of just corroborating that it's not just the high allergy risk babies that this is true for. This is true generally, that, the earlier the gut sees the food, and, if you are able to beat the race between the gut and the skin seeing the food, you really reduce the risk of food allergies in any patient.
Wow. And again, that's a radical change, and that's occurred like basically in the last 6 years, you're saying. So 6, 7 years ago.
Yeah, it's been almost a decade. I say 2016, but it's almost been a decade. But as you know, knowledge translation can be quite slow. And, the trickling effect I feel like, I think 2016 on, we really sort of shifted our practice in primary care offices, where we started telling patients, okay, when your child is developmentally ready to have food, introduce it. Don't wait.
So here's another question then. Might be a sort of a myth. Can what a woman eats during pregnancy, can a woman's diet during pregnancy, can that trigger an allergy in her baby?
Oh, Ian, you hit a nerve. This is a hill that I might die on. I find that parents are frequently sort of blamed and shamed for a lot of things, a lot of things that happen to their babies. And there is absolutely no convincing evidence that anything that a mom does or eats during pregnancy has any effect on the child's likelihood of having allergies. And this includes in lactation, right? Unless there's a very specific case where the child has a diagnosis called CMPI, cow's milk protein induced proctocolitis, or it's called allergic proctocolitis now. So if that's the case, then maybe there needs to be some restrictions with the mom's diet. Even that has pretty weak evidence. So nothing that you've done in pregnancy, nothing that you've done during breastfeeding has any impact on the baby's chance of developing allergy. It's really the
Wow.
baby themselves getting the food particle in their gut rather than through their skin.
Right. And is it true then, and infants can be tested, right, for a food allergy? I guess I'm looking at a myth here that no, you can't administer these tests to young infants, but that's not the case?
Oh, I really appreciate that you brought that up. Yes, we sometimes hear that there seems to be this impression that kids need to be a certain age in order to get tested. Not so. In fact, like I said, we actually urgently prioritize the little ones so that we can prevent food allergies in them if there's a worry of a food allergy, or we can sort of make some adjustments to their diet if there's an issue with any other kinds of immune reactions to food. So allergists and immunologists are actually double certified to see both pediatric and adult populations. So anything from cradle to grave we see.
And again, then, so I guess another myth linked to all this might be that babies are at high risk. I guess, some parents, it's nerve-wracking when you're a new parent and you think, oh my God, something could happen. But in fact, that's not the case, right? That infants, well, I don't know what I'm saying now, are not at high risk of developing a food allergy, correct? When they're very, very young?
Food allergy reaction, you mean? That's right. So
Right.
all of the data that we have so far show that infants who have allergic reactions on first exposure to a food, that first exposure reaction, if it's going to be an allergic reaction, tends to be mild because they just simply don't have the immune system maturity to mount a robust enough response. That being said, I'm a parent myself. I completely understand what it feels like to have, concerns and worries about particular issues about your child. So if a parent is concerned, we sort of work through those concerns and try to introduce the food to the best, while maximizing everyone's comfort. So it's always a shared decision. And I tend to think caregiver instincts are typically right. If a parent is worried, their spidey senses are tingling, I respect that.
Right. So let's jump to treatment then. So a child who has been diagnosed with a food allergy, what are the treatment options?
Treatment options have also undergone a pretty big paradigm shift. Previously, the only option really was you have an anaphylactic allergy, you have to avoid the food for life, carry an EpiPen if you have an exposure to, and I say EpiPen, but I mean epinephrine auto-injectors, sorry. So, you carry epinephrine, and, if you have a reaction, you treat the reaction. So that is the long-standing option for food allergies. A sort of a newer option is something called oral immunotherapy with foods, or desensitization to foods. We can, if we intervene early enough, we can actually introduce minuscule levels of food that the patient is allergic to back into their life and sort of keep the immune system desensitized to a specific quantity of that food protein their entire life, so that if the patient is accidentally exposed to the food, if they're exposed to the amount that they're already desensitized to, it's predicted to not cause a reaction. So that's called oral immunotherapy or desensitization, and that exists for most commonly peanut, but it exists for really every food. We just had to sort of intervene early in this situation because the older you are, and by older I mean actually past preschool age, the more your immune system gets set in its ways, and the oral immunotherapy process is rife with more adverse side effects and such. Whereas if we intervene before age 1, if we intervene before age 6, the process goes really smoothly, and they actually work up to a significant quantity of the food that they're allergic to by actually increasing their dietary amount of it over a period of a few months to a year. So we do that at St. Joseph's all the time.
Excellent. And what about stigma or social attitudes? Obviously I'm older, and for many years, there was maybe this kind of, it was often dismissed. I think people would roll their eyes and think, oh, can't eat peanut butter, but have attitudes changed, do you think? I
would the naive part of me would like to think so, but unfortunately I don't. I do think there's quite a bit of, what's it called? Medical gaslighting, I guess. There's a bit of gaslighting of individuals who have a diagnosis of allergy. And I think part of the reason why that is because the term allergy is, often used inappropriately, right? So anaphylaxis to a food is life-threatening, and that's certainly not the same kind of reaction as having an intolerance to a food, right? For example, if you have lactose intolerance, if you have milk, you'll have stomach cramps, you'll have nausea, vomiting, diarrhea. Is that life-threatening? No. Milk allergy, on the other hand, much of the headlines that you read about anaphylactic deaths in the media are related to milk exposure. So milk anaphylaxis is quite serious, but the label of allergy, I think, has become a bit diluted. And you're right, there's sometimes sort of a mocking of it. In schools, we often hear about kids being bullied and sort of, isolated because of their allergies. And there's a lot of mainstream sort of dialogue about how, why should we treat this person, differently?
Why does my child have to refrain from taking peanut butter to the lunchroom just because someone else is allergic to it, right?
Which is, a whole other issue, Ian. I'm actually not a proponent of allergen-free schools. I'm a proponent of teaching staff and teaching kids and families to manage allergies rather than, making the environment even more sterile. So there's actually been systematic reviews of whether it's beneficial to keep allergens out of schools, and the evidence is not in favor of it.
Yeah, you were saying about the difference between managing food intolerance, food allergies, rather than eliminating it in a school setting. Do you have any advice or tips as to how an agency, a school, an organization can do that in a setting?
Yeah, I think educating and empowering patients around allergy is one of the most important things that we can do. And every patient that we see in allergy clinic gets education on how to use an EpiPen. And actually, a lot of them leave the clinic with their own needleless training devices. And we often say, hey, teach everyone around you how to use this, so that you can take some of the drama out of it, right? Because, I don't know why, but there's this image that, oh my gosh, Epi is the last resort. And, it's very dramatic. There's lots of sort of clips that I see of people just like doing these dramatic arcs into their legs or even chest with EpiPen. But, one really important thing I can do today even is just to tell you, if you have anaphylaxis, the best thing that you can do is use an EpiPen. Learn how to use an EpiPen. I can do it in 1 quick minute. Basically, if you're having anaphylaxis, you lie down. If you're not having lots of difficulty breathing, you lie down to get the blood to your heart and your brain. Then you put the EpiPen, you basically gently place it against your thigh, your outer thigh, around the midway point of your outer thigh, and you hold it in until it clicks. You hold it in for about 1 to 3 seconds, and you're done. And that will take a lot of the risk of having rebound anaphylaxis, having protracted anaphylaxis out of the episode. That simple bit of learning, I think, needs to happen at workplaces and schools. And, I personally have offered it to my son's school. I just recently did the presentation to the little kiddies and the teachers. I've never been so nervous because 4th and 6th graders can be judgy. But, I think it's a really high yield, it's a high return on an investment process to go through for every single school.
Oh, that's fascinating. So as you said, a lot of people may go online and they're offered, they stumble upon a test. And you said this is called a panel test. What does that mean? How does the test take place?
These food panel tests are ubiquitous. They're actually available at some, outpatient laboratories, and, they're widely advertised. They tend to be expensive. So these food tests actually pick up on an antibody called a tolerant antibody in patients. So you do this test, and I think it checks for, 200 to 400 different foods. And typically the results come out as milk, egg, wheat being the top 3 things, because, like I said, it picks up tolerant antibodies, and most people consume a lot of milk, egg, wheat. So it picks up those antibodies. People end up avoiding those foods or avoiding other sort of random foods that come up on this test. And, it's really not an appropriate way to diagnose food allergy. It picks up on the wrong kind of immune component to diagnose a food allergy. And I think it does patients a lot of disservice because, they're sort of lulled into a sense of thinking, oh, well, this is it. I should avoid milk, egg, and wheat. What often ends up happening is if you avoid milk, egg, and wheat, your diet becomes quite restricted. And, you might start eating a lot of vegetables, lean proteins, etc. Most people tend to lose weight on it. Most people tend to feel excellent. And, they attribute it to the test results, but really it's them making healthier lifestyle choices. The test, kind of grabs a lot of money out of their pockets, but it really is an inappropriate test. It should not be used. Our National Allergy and Immunology Society has put out statements on why. Most allergists will tell you that, it's actually dangerous because it's not going to pick up the food that you're allergic to, right? It's going to, number one, pick up wrong foods that you're not really adversely reacting to. And secondly, it's not going to pick up your anaphylactic allergies. So I really dislike that this test is so ubiquitously out there.
Right. And sorry, the actual test itself, is it it's called a blood test or?
It's a blood test. That's right. Yeah.
Okay. I see.
It is a blood test.
Right.
Yeah. And when I see that a patient bringing in a binder full of results from this blood test, I wonder about how much money has left their pocket, And I have to say, I don't blame the patient at all for trying to advocate for themselves and try to figure out what is going on with their body. What I don't like is somebody taking advantage of that vulnerability and sort of exploiting that vulnerability.
Well, I have no idea. That's a good warning for our listeners out there.
I actually saw it on a show called Dragon's Den or Shark's Tank, one of those things. And it was actually being advertised and, triggered.
Oh, wow. Did they get funding on that show for their idea?
I could not watch that episode through. I could not, but I bet you they did.
Wow.
Because, many of these scams tend to be packaged in a very attractive way.
Okay. Well, we covered a lot of topics and we're, I think, sort of run out of time here. So fascinating stuff. I learned a lot and I hope our listeners did too. Dr. Jeimy, thank you so much for joining us today on the DocTalks podcast.
Thank you for having me.
That's it for this episode of the DocTalks podcast. Thanks for joining us, and join us next time when we'll continue our conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. Be sure to subscribe and follow us on Facebook and Twitter at St. Joseph's London, or visit sjhc.london.on.ca/podcast. Until then, stay healthy.